The Vedic system, that is the fourth generation robot. This is the latest one. We had this since last 1.5 years at Lokmanya. So in this you get all this mapping is done. The pictures look like this. Then you have mapping of the condyles like this. And then you get all these figures. So how much is the virus, how much is the gap. So there is nothing again left to imagination. You adjust your processes in proper place and then you cut the board. So this is the DL cut now. This is the saw-based system, and you don't have to. There is nothing, no jigs, nothing is used. This is the one particular intelligent handpiece will carry out entire tasks for you. So all these messy trays are replaced with just one stand and one robotic arm. Then you put this tensioner to understand the tensions in the contractures of the ligaments and take the knee to the range of movement. So you get all these graphs and you understand this. And you can have a balancing screen like this. You can see on the right hand side, on the left hand side, you can see that the joint is absolutely some millimeter accuracy. It is completely balanced. You can see 10.5, 10.5, 10. So within 1 millimeter balancing is there. So that's accuracy which robot brings in picture. Once we do this, then we go to the femoral cuts because that is a one more chance. If there is something wrong in the graph, you can still adjust on the femoral side and get your things right. So this is how the femur is prepared. Again, in the soft, no jigs are required. You can reconfirm the cut with this rope that will show that the cut is absolutely perfect. So this is how all the 4 cuts are being taken. And it is absolutely optimum accuracy there and very convenient. You can see the assistants are not required, with self-hitting, retractors, everything is absolutely very smooth. And then finally you get this graph, and this is how it fixes it. So let's go to some of the review of literature. There are many papers now which have come up. The robots are in place now, almost 1.5 decades they are there. So this is a study where CT-based analysis was done, and it showed more accuracy in robotic surgery. Advantages of robotic TKR is again showing this paper also showing greater component accuracy. This paper shows that outliers at 20% in conventional surgery, whereas in robotic it had come down to 3%. In this paper again, it shows some similar results. There were no outliers in robotic surgery, so whatever you plan, you get whatever you plan. The implementation and execution was absolutely perfect. So this is how robotics has brought in a great sort of accuracy in the surgery. The recovery time, because your soft tissue releases are very minimal or not there, just bone implant placement varies. There is less bleeding, there is less sort of hospital stay and early discharge, less pain. So there are a lot of advantages of robotic surgery. There are 10-year follow-up studies also showing better results for robotic surgery. So there are a lot of, in literature, there are a lot of papers. This was our paper, which was done for high-risk patients like CABG patients. In conventional, you had to put the intramedullary rod, and that gave chances of fat embolism syndrome, which is now completely taken off. We don't have chances of fat embolism here because we are not putting anything intramedullary. We again published a paper in the Journal of Arthroplasty where joint line restoration was absolutely perfect with robotic surgery, and that is how it has patient satisfaction is great. There is no patella alta, patella baja in these situations. So the robotics is here going to stay, and it is going to be there in practice, and I'm very sure they are going to be in work until very soon. Let's see some of the patients. Bilateral rheumatoid arthritis patient walking with a limp. 3 weeks post-operatively, completely gait has improved. This is how independently she can climb the steps also. Another patient with very great 30-degree varus deformity, completely with fixed flexion deformity. About 6 weeks post-operatively, walking without any stick or walker. Deformity is completely corrected. Steps also, he can start going. Our protocol is that we make the patient walk next day. In about 10 days time, the stick or walker goes, and we do bilateral single stick TKRs. Both the knees are done at the same time. And after that, the patient goes on the steps in 3rd day and is discharged on the 3rd or 4th day. The patient can drive vehicles also within a matter of 2 months. Another patient with very gross deformity with waggling type of gait. He has got 20-30 degrees of flexion deformity, very bad, rigid varus. about 2 months post-operatively, he is absolutely independent. Another case, very bad case, you can see that the stiffness of the leg, patient is crippled, rheumatoid arthritis patient, bilateral TKR. This is 2 months post-operatively. Walker has gone, her life, quality of life has improved tremendously. So this is how the quality of life actually improves after knee replacement. Another patient with a bad Walker's deformity, she is even unable to walk also. Her deformities were corrected, and now she can actually go to even sports activities. She is doing this, spinning and bicycling also. So that is the joy of motion which is given to the person. I always tell my residents that movement is life, life is movement. If your movement is gone from life, then it is actually going to be very difficult. So there are, number of patients. So many patients are there who are, like crippled like this. And in India also there are a lot of misconceptions about knee replacement. But the more successful patients, the more they bring other patients, and that is how the practice goes on increasing. And now we get so many international patients. I have even operated many patients from your country also, from Middle East, Bangladesh. And this is a patient without now Walker is on in 1 month post-operative. And patients actually can dance also. So this is the joy of motion. This is a patient where she has to use, this is 2-6, you can see the instability in the left leg, anytime you can subluxate or dislocate and get fracture. Same patient 2 months after post-operatively, no walker, no stick, walks normally. You have to actually tell that you did surgery in this patient. That is a fantastic result what we get. This was a retired military officer. Due to his heavy, hectic life, his knees were degenerated and he started getting badly. We corrected his knees, and I think he can be again fit to go back immediately. See the way he's walking. So that is how there is a fantastic, and this is not surgery for only rich people. We have a lot of poverty in India, and we offer them very good packages, and we have some schemes also where we offer to all the patients. There are so many farmers in India. India is a lot of villages and farming districts. They need to sit down and they need to do this. So this next slide, I am not going to talk much. This lady I operated about 10 years back. She is now able to sit cross-legged. It is very important in Indian culture that they are able to sit down. The earlier technology was not permitting us to, patients to do that. And this is not only that, she was burdened to her family because of her disability. And now she goes to the farm, she always, see the parents she's walking. So all the ligaments are preserved, so the proprioception also is great. The position sense is great. So patient is very happy. That is the thing. She sees the surface on which she is walking without any walking aid. Even the younger people are falling behind. This is how she is walking. She is squatting down, she is doing farming work. So that is, she has gone back as a earning member of the family now, from a burden to the family. So all sorts of activities these people are doing. And they are happy like because people they don't take them as a burden, and they do all sorts of farming work and so it's offered to everybody. She is not from very affluent family, but at Lokman, as I told, we help them financially also wherever it is required. And this is the most difficult task. To come down this steep slope. Even for us also it is very difficult. But this champion lady is able to do that without any support, and she is almost running down the slope. So that is a great proprioception. So really patients do wonderfully well if they are motivated. And that's why we are offering indeed. I discussed with my friend and my brother, Dr. Viru. You can note down the numbers also. PT is here and Shreya is also here. People who are interested, we will be very glad to offer fellowship not only in joint replacement, but in spine surgery, in trauma surgery, and arthroscopy sports medicine. So you can contact us and definitely we will be offering them. Thank you very much.
Thank you, Prof. So we had very interesting 2 presentations. We're going to have around 15 minutes for questions and discussions. So I think both presentations are extremely interesting for us. So residents, don't be shy. Seniors, please share your experiences, and yeah, let's start the discussion.
Presenters, please. Over there. So, thank you, all the speakers. So we'll start with questions from the audience. Anybody wants to take that?
I have a question for Dr. Murthy.
We'll come back to you. And we will come back.
I really appreciate your presentation and the difficulties what they have, especially in the home sector, the gangrene happening. And in India, in 90s, the condition was almost same. From various patients, they not reached out to the home sector. So we have gone through this journey, and last 3-4 decades we have progressed in this thing. What are your opinion of starting a sort of pre-hospital trauma care? That is very important, and I don't think that is existing here in India.
One of the things that we managed to do in Ghana with the traditional bone centers is there was a group of surgeons who were very interested in developing educational material that was aimed at preventing the preventable complications of traditional bone setting, as well as establishing a referral pathway for traditional bone centers to refer patients to the hospital. So we evolved. There was a lot of leadership, even at the level of certain areas in Ghana. We recruited the leaders, traditional bone center leaders. We recruited a geolocalizer. We developed the curriculum over, it took us about 6 months to backwards plan, do the competencies that we thought. So we developed around diagnoses, treatment of what they can treat, refer what they can't treat, medical records, lean management, and ethics. And then you have to pay for this. So you have to invite them to a session. And right now we've been able to run 5 of these sessions in Ghana. We're trying to do the same thing right now in Tanzania, in the northwestern part of Tanzania. So rather than taking the stick approach, taking the care approach, it's still not perfect. Even in Ghana, I was there about a month ago, and we were doing one of these education sessions. And during the course of the 4-day course, there was an emergency powwow because a young girl had fallen at school, and she had stopped the treatment of a traditional bone center. She had bilateral undisplaced distal radius fractures, and she's now got very high below elbow amputations. And the question now is what to do next. The family, the boss of the traditional bone center local chapter wanted to bring this guy up on criminal charges. But the family did not want to do anything because of this spiritual belief that if they anger this traditional bone center, that they will be cursed for life. So he was brought in for a little bit of a fireside chit chat, but it's still a problem, and it's still a problem. I think it's still a problem in India as well. And they're not going to go away because there's just not enough of you. And there's not enough of you to take care of all the problems, and there's not enough money also for people to be able to access what I would call orthodox orthopedic treatment. Sorry for the long and windy response.
And India also is like there now it is mainly the territory in the tribal areas, the areas, the bone center problems.
Okay, thank you. My question is for Dr. Arena. First of all, I'd like to say thank you for your enlightening presentation. So, I think my question is, what is the role of clinical information? The role of clinical information in using the robot test.
3D printing also is coming in a big way, especially it is very important in understanding and getting one of the custom-made implants also with 3D printing. It is very important in especially hip surgery. And when you require, let's say, a particular deformed acetabulum to replace or to have bone defect planning, then that is the time when 3D printing is operated. And there are a couple of companies in my city of Pune who are actually giving us 3D printed implants in difficult situations, especially in acetabular side. It's very important. In knee surgery, 3D printing has a very limited role. If there is a deformed sort of a bone, for example, we use bone defects, we do neglected long time disease, or post-traumatic, especially post-traumatic arthritis. If there was a trauma with a say depressed medial or microcondylar fracture, we just got rotated and to implement, get implant right in that 3D printing is a good idea. But 3D printing, then augmented reality, virtual reality, and as we were talking in coming day, I am also working on a project of AI. AI also is going to come in after robotics. The next step is going to be artificial intelligence. So I think the science is just going to go leaps and bounds.
Thank you very much for your insightful presentation. This is for Dr. Narendra. We see from your presentation that robotic surgery is having less complication, less time consuming, and rehabilitation process is very fantastic. Again, thank you for this insightful and eye-opening presentation for us. So my question was like, how is the affordability of this procedure compared to the traditional way of robotic surgeries? Can people afford for it, or is there a system which covers the cost to do it for any patients? Thank you.
Yeah, so you can also add this, during the development interface, it's still at infancy. So it's not something that we can easily make available for the whole patient that need. So how much of your great percentage is robotic assisted? And what are your actual cases that you would need it? And is there actually clinical superiority in routine knee replacement? You can, with the post you can actually elaborate this.
Yeah, regarding the affordability, basically the cost in India for knee replacements are very, very less as compared to the Western countries. I'm not exactly sure what are the costs in Ethiopia, but they are very affordable. And we don't charge anything extra apart from the disposables which we have to use for this. Especially the crackers and the pearl, these are two disposable things in the trays. So the patient is charged only extra amount is about that. That comes to about, you can say, about 700 to 1,000 USD, something like that. Indication for okay. Yeah. So actually, the first is that one patient comes to us. We explain about the possibility that you can do by conventional and this advantages and downsides. Downside mainly is that $700, $800 of additional cost, which some of the insurance companies don't give, and the patient has to spend from the pocket. So they, some patients say that you pay, or some patients don't. Medical indications or clinical indications, I think more the deformed case, the more indications for robotic surgery. As far as the partial knee replacement or unicompartmental is concerned, 100% is good robotic, because that is one area where robots have clearly proven to be very, very effective. And every time, because otherwise, if you see the results of partial replacement, this gained popularity and then it went down. And just with the Oxford knee, some students who were doing regularly high volume cases, their results were good, but otherwise partials were failing because the accuracy of implantation was not very optimal. The instrumentation was not optimum for partials. So all partials, which are around, we do around 500 replacements in a month in my hospital, which is the high volume center. Out of which about 20% now go for new, and they are all robotic surgery. As far as the TBR is concerned, around 50% of our patients have opt for robotic surgery. So more deformities, the patient having more bone defects, the robots give you a better understanding. So in those cases, definitely robotic is a clinical indication for that. But now, more and more patients are adopting robotic.
Okay, thank you. Dr. Mandel, I have a question for you that as the starters, beginning, we are at the beginning of the joint replacement in this chapter. So since you are the pioneer in the country of this replacement, what kind of advice do you have for these organizations at the beginning stage of joint replacement, especially knee replacements, where giving advice and persuading the patient is very difficult at this point?
So I'll tell you what we have gone through. Actually, when I started practice in 1990, yearly I used to do hardly 5 to 7 patients. Now we're doing 500 per month, and I have seen all the journey, gone through exactly the same difficulties what people are facing right now. And very relevant question and very important one also. There are two things. Number one, there are patients in the community. Dr. Birut mentioned in his speech that your longevity is going up now. So 65 is an average in spite of your infant mortality or children mortality, trauma mortality, which is mainly in the younger age, the mobile age. So in spite of all these things, if your life expectancy is 65, there are going to be more and more degenerative diseases in the community and lifestyle diseases, and that is how the patient profile is today. Now there are a lot of misconceptions. The biggest difficulty which I faced during this thing that there were two groups. Very small number of surgeons, including myself, who were arthroplastic surgeons. Rest of the orthopedic community was non-orthopedic. And that was the first beginning, that was because the patient used to go to colleagues, senior colleagues, used to say, no, the result may not be optimum and just be happy with what you are going to do. Some were giving just steroid injections, some were giving some manipulation, knee pads, etc. And the patient used to carry it. Now, if the doctor himself is not convinced, then the patient doesn't get convinced. So first thing was that we like your Esot. In our country, we have got various organizations. We started Arthroplasty Association in India, where we started regular meeting. Initially, it was a half-day meeting. Now it is a 3-day meeting with almost 500 arthroplasty surgeons only practicing arthroplasty in India. So I think you need to start educating programs for your colleagues. Have an arthroplasty meeting here. So the concept of arthroplasty is first of all driven deep into minds of orthopedic surgeons. Number two, awareness of in the community. So what we did is that we requested state-owned television company, which is actually government agency, that you should invite doctors for our TV talk shows, health-related talk shows, where we show all these videos of the patients, where pre-operative weight, post-operative, just like what I showed, and explain in simple words what is the knee replacement procedure. Okay, then this was explained directly to the patient, TV audience. Now there are social media also, you have YouTube also. So start educating the common people. They should know that there is a good treatment available for this and there is no need to get crippled. And that is why I think two things. One, start educating your peers and your colleagues on the procedure, start having meetings here. Anytime you require my help or involvement, I am very much keen to come here and talk. Start from basics and then go to robotics. So it should be a complete arthroplasty meeting. Maybe a half day, 1 day or something like that, community education. I think these two things, definitely there are a lot of patients in the community, and I'm sure if they are coming to India for replacement, they should come to you here. And I really like this concept of reverse medical tourism. It's very easy for a doctor to come. If you cluster cases, our team can come and help you in the initial cases. Even we are going to install and have collaboration with centers of hospitals.
We have two more talks, and one is so we will take the last one comment, then I will summarize and prepare the next talks.
Thank you very much. There is some type of comment, not question, regarding these bone healers. I think this training process is not only in Africa, in Nigeria, they are doing every 6 months. and then they have a good result on that. Even in our country, there is one surgeon who did 1,000 area, some, I think, 8 to 10 years back. He collected all ball healers, and then he told them basic 4 things. 1, no price damage. Second, keep elevated all injured limb. The third one is, if you split in halfway, you can keep immobile. Their fracture side. And then here is a study that was published in GPGS, and then 85% of all these bone centers, they improved their way of treatment. When I was active in EO system, even with Professor Jim Harrison, we talked about these things. Dr. Sam Victoria, we thought how we can collect and how we, in the process, not taking patients from the bone centers. It's simply we keep them. The fourth thing is which type of patient can be referred to the other level. If we do these 4 things, I think the process is less. And the other thing what we see as working we as unit, more victims for this treatment are the children. They are judged by the family, they are judged by the bone sitters, and then they get into that. I think we have a good paper which is published. A number of patients they lost their limbs, so that air still is point that it is good to give them this direction, and I think it can bring a lot of changes. The main important is the way of living. If you take all the patients from the bone centers, and then bone centers are already made with the human beings. We are new to treat with the modern technique. And then the society is more trust to the bone centers than us. So let's have to understand this point, and then this is what I want to say. Thank you very much.
If I can add just one comment with the other thing that we do that's done as part of the educational event with the traditional bone centers is they come to visit the hospital and make rounds on the wards to see what kind of treatment is available. And you're right, Peter, it's about really preventing preventable complications. And the preventable complications, like you said, is no more tight vessels. And if you just take that away, you're going to prevent those preventable complications, refer the open fractures and the long shaft fractures, and anything that's pediatric elbow, send it to someone else. And if you can just tackle those particular things, you'll make a dent in what I would call the preventable complications. Thank you.
Let's summarize. Thank you. The concept talks, the dialogue, the technologies, and the rest. You can do conversations, for example, lunch times or meetings, even later after the meetings. We saw 2 extremes, if you notice. We talked about the dark age of bone setting and infections, gangrene, tight splints, bamboos, stuff like that. And the future, robotics and AI, artificial intelligence. And in this room, even the surgeons are on soft newly emerging youngsters who are aspiring. Now we're thinking about using AI when they become fellows, when they become consultants, like us one day. But we have to balance with the transition. There is a role that we play. How to transit from there to here. In between, how to do the transition smoothly. For this important point, Cloud mentioned is we are very few. Numbers are important. We are only 600 in the whole job. 600 orthopedic centers. We can't cover this population. Even we have not 1,000. That's the minimum number. The virtual list is 10,000. But even that, we are not 1,000. There is a long way to go. But in between, what include there are practitioners, nurses, midwives, and home to home, we have 40,000 plus, health workers. But to train all of this, and raise a force and element of awareness that prevents disabilities from and disasters happening from high spirits and these bamboo things. The second thing is we have to get our parents and brothers always left and right to shout. You have to subspecialize. Everybody is a specialist, but we all have differential according to our interests, subspecialize. Some nurses that we mentioned, they can talk, they have 3-4 fellowships. I know it is fine, I know we did fellowships for every 4 major joints and then. So, forget one subspecialty, you have to do 2, 3, 4. That's the way forward. Then the young listeners who came here, the only message from this conference I want to convey is plan on education, plan on your subspecialty, if not subspecialties. Then come back, then ask about equipment, form small associations, advocate, teach, post, lecture. I enjoy always when you post something. I told myself, I can make many. You post everywhere what you share. That's important. You advocate. The society chooses between those bamboos versus the patient. The last patient who is all working. We live that process. Until then, the senior ones, let's do the transition. How to smoothly transit from the Western civilization. If you go to 15th century, 16th century, 17th century, where's there? There were there. The sweet family from UK moved US and they were practicing there. They wrote books. Without X-ray, they functioned. They were there. They existed. But where are they now? With the developed countries. So it's not 5 that statistics. It is outshining, coming with numbers, coming with better results, coming with better function, coming with better infrastructure, coming with development. As our nation develops, we will be like the developed countries. That time, I don't think this will be an agenda. With that, let's summarize the presentation. The second talk is online. I think it's for time to be precise. I would like to, in terms of time, please humbly approach you outside at breaks, at lunch. Tomorrow also, we have similar talks, communicate with them, have dialogue, conversations. For now, let us all thank them and they can be seated. Thank you.
Okay, so thank you for our moderators and our presenters for wonderful presentations. Unfortunately, the next presenter is going to take a few minutes to log in through Zoom because he cannot be here physically. So if there are any more questions or anything, comments until that, then we can take some comments and questions while we're waiting. Any questions, comments, or add? I don't know, maybe for question for Claude, how do you see the role of the surgeon as a leader? Because all these things you talked about, changing trauma management and everything, are multi-level, right? It's not just at the level of the hospital, but at the level of ministries and even at the level of policymakers. So what do you suggest for surgeons who are usually in the OR all the time? How should they approach the subject so that they can have a wider impact and make sure it's incorporated into health policies of the countries?
I did my orthopedic training in Canada, and Canada has what's called the CANHEADS competencies, the American system has different competencies. And those CANHEADS
ከፍ ብለን
competencies
የተቀበልነው
And there's a couple of, one of them is you are a leader. Obviously, the biggest competency is your knowledge, skills, and attitude. But one of them is your leader. Okay, and that's various levels at the leading level of your hospital, your department, your program, etc. The other one is your own advocate, and that starts with patient advocacy. So you have to be the advocate for your patient as well. So those second competition, you can look at, you can look it up, it's called CANMEDS, CANMEDS. And if you put that in Google, it'll take you to the Royal College of Surgeons of Canada website. It's all available for free. There's a lot of different levels of where the residency programs are supposed to be developed. But one of the two important ones that kind of get left out because you're so busy taking care of patients is the leadership ones and the advocacy ones. Now, I think the other thing where we as orthopedic surgeons do really, let's call it a shitty job, a poor job, is that musculoskeletal health. So, you're running very busy fracture clinics and clinics overall. Sometimes there's the communication gaps as well. And I think we do a really poor job at educating our patients about musculoskeletal health. Not just about their fractures, but about health to improve that. And I think that's where social media can come into play. In other countries, we help run a workshop for journalists that report on injuries. So they report on car accidents, on truck accidents, and we run a workshop to give them basically anatomy 101, and also the impact of injuries on the population. So some of the slides that I showed, and this goes to the awareness and also some of the policy advice. And this is where I want to work with. We've done this in the Gambia, where we work with leaders, not just trauma orthopedics, but anesthesia, police, firefighters, ambulance, to develop this integrated national trauma and injury plan. It's not it doesn't include everything, but it's very specific for trauma and orthopedic injuries. Now, it's a little bit, probably a bit more difficult to do in Ethiopia because of the sheer size of the country. But now I have a question for you. We got a little bit of time to go, don't allow me a minute. So you saw the three diagnoses we picked up: closed ankle fractures, closed femoral shaft fractures, and open tibia shaft fractures. If you were to pick the next three common orthopedic trauma injuries, diagnoses that really make up a good bulk of your daily life, which ones would those be? Anyone? Which ones would those be? What's causing you problems in your practice right now where there's so much variation from one hospital to the other, where you'd like to have some guidelines to help you out? In pediatrics. Okay. So tell me a little about pediatric supranuclear fractures. Now, I know you're a pediatric orthopedic surgeon, so you have a special interest. But what's the breadth of treatment that you're seeing in this country right now?
I just been play with Arabic.
What kind of complications?
We see lots of deformities, we see lots of death presentations, we see lots of bone segment frequencies and amputations from those injuries. So it would be good to address that.
What would be your developing those standards of those clinical guidelines? What would be your recommendations in terms of the aspirational treatment? Obviously, getting to the right doctor at the right time. Let's assume that you can see them within 5 days. They show up. Let's call them and you'll figure out about the displacement numbers, right? I think that's where you're going to start. Type 1, type 2, type 3s. Now, what would be your recommendations for type 3s?
In a place where you have the serum facility.
Okay, so we have to figure out is a serum available or is a serum not available? So we have to account for that variability. What else?
Available skills.
I'm sorry?
Available skills to the care.
The ability to train the skills. Okay, what else?
And also
actually download እስኪያደርጉ እንዳይቆራረጥብን ኦንላይን ቪዲዮዎች ዳውንሎድ ሆኗል። ኔትወርክ ሁለት ያደርገው ሶስት የዛኛው ሪሞት ተመስል ይኸኛው እያደረገ ነው። እዚህ ማለት ነው ከዚሁ ላይ የትኛው ሂውመርኔት ምናምን የሚለው 10 ደቂቃ ነገ ነው እሱ። አሁን ግን እነዚህ ሁለቱ መሰለኝ ይኸኛውና ይኸኛው የነገ ነው። እሱ የነገ መሰለኝ ያጽብናል። ከዛ በኋላ ሁለቱ ገብቷል ግን የነገ ነው አለኝ አይደል? ይኸኛውና ይኸኛው ነው የሚፈልገው። ይሄ እሷ ቦታ ካንተ ልኬለታለሁ እኮ ደርሶታል። ኢሜይሉን ቼክ ያድርግ። እውነት ልኬለታለሁ እርግጠኛ ስለሆንኩ
Another diagnosis. Yes, Dr.
Thank you very much. For us, the commonest problem was facing not only us, but all
የመጀመሪያው ፕሬዘንቴሽን በዚህ ሶስት ደቂቃ ብሎ ኢሜይል ያለው ዋትሳፕ
ኮኔክሽናቸው በጣም ባይዘው ኢንተርኔት ይህም ተደርጎ እሱ ሲገባ ኢንተርኔት ውስጥ የሚለፍረው ዳውንሎድ ካረግ ዳውንሎድ እስኪያልቅ ድረስ ከገባ ገባ፣ ካልገባ actually save ማድረግ እንችላለን።
the general surgeons what they did when they saw they born plus.
ይሄ ሁለተኛው ቪዲዮ ነው። ይሄኛው
All the surgeons what they do, they remove that the ground of bone, and there is no any supporting inside the body for the movement, and then the patient is line limb, and then remove that limbs, and then fix this stasis. That's the case. Well, that is problem. It's a big problem. I think young orthopedic surgeons very are facing the same thing. We work at almost
ይህ የመጀመሪው ቪዲዮ ማለት
6
ነው።
years.
የመጀመሪው ቪዲዮ
This is one of the common problems of the place. And hopefully the same process will work. And everybody knows that.
The TB diagnosis.
ይኸኛውን
Yes.
ፕሌይ ማድረግ እንችላለን። ሰውየው አልገባም።
We look for another diagnosis.
እንደውም እንገላግለዋለን እንጂ አንዱ ቀርቧል አንዱ እንገባለን።
Okay, thank you for the chance. So.
ሌላ ቪዲዮ አለ የሚቀጥል
አይ ላይፍ
Let's call it a protocol because it's a protocol you have to follow it.
Okay, let's stick to clinical guidelines, standards of care, which allow you a little bit of what I would call waffle.
So I go with the Esot, especially patients. So essentially regarding to classify
አንደኛው አልቋል። የመጀመሪያ
ዳውንሎድ አድርጎ አልጨረሰም ቪዲዮ። የመጀመሪያው
ይሄኛው ነው
አይደለም እሱ ነው የመጀመሪያው። እስቲ ፕሪቬንሽን እስቲ ወደታች ነው
ምንድን ነች?
አይደለም እሷ የሳይን ናት ዩዘር ክሊያወራች
የመጀመሪያው ቪዲዮ
አይደለም። እስቲ ይሄኛው አይደለም በቃ ይሄ ማለት ነው።
ይሄ ማለት ይሄኛው ነው።
ዳውንሎድ እያደረገ ያለው
ይሄኛው ሁለተኛ ቪዲዮ
እሱ ሁለተኛ ነው። የመጀመሪያው ዴፊኒሽን ኤንድ ዲያግኖስ አልጎሪዝም የሚለው
እሱ ዳውንሎድ እየሆነ ነው ማለት ነው። ላይ ላይ መክፈት እኮ እንችላለን። አይቆራረጥም። አይቆራረጥም።
Thank you very much.
There are few limitations. Okay, so open fractures obviously we have to do something. Fractures involving the humerus is common.
ይቻላል።
To fracture
እሺ
the wrist and also there's a fracture of the distal leaves or fracture of the heel shaft. But I think that as regards to
ረዘም ማለት ነው። አክቲንግ ገብቷል ሰውየው።
Okay, thank you very much, everyone.
Thank you so much, Dr. Paul. So we're going to continue with our two other presentations. It's going to be given by Mario Morgenstern. He works at the Center for Musculoskeletal Infection and Department of Orthopedic Surgery and Traumatology at University Hospital of Basel in Germany. He has over 70 publications. Oh, so apologies. He has over 17 publications, and he's written many book chapters, including soft tissue infection and the AO infection manual and treatment for fracture-related infection, and the textbook of polytrauma management. So I think he's ready and online for his presentation. I would like to call upon the moderators, Dr. Elias, Dr. Johannes, apologies, and Dr. Moa, to moderate these two sessions. Dr. Elias, Dr. Elias, and Dr. Moa. Dr. Moa and Dr. Elias. Okay, maybe Dr. Efren or Dr. Zagana can take the spot for Dr. Elias. Are you ready?
Yeah.
Okay.
Thank you.
Yes, please. Go ahead. Not yet. Yeah.
ነገሮችን ሼር ማድረግ አለብን። ፕሬዘንት ነው አይደለም እንትን እያልኩት ነው።
Okay, we can see it now. Yeah. Not yet.
ችግር የለውም እኮ ነበረ ቪዲዮ ያስመጣ ነው ለዚህ ነበር ስለዚህ
So who do I send the IT bill to?
No, it's better to continue with the second talk and then we'll have discussion. Would you make it to continue? Mari. We can continue with the second presentation. Can you hear me? You are not listening. Mari, we can continue. The second. Yes.
I think we'll stop here. We're running late for lunch, so. But we're gonna have questions for you, so. Okay, good. So we're gonna take like 2, 3 questions because we're running out of time before lunch break. So anybody who has questions?
Thank you very much. You hear me? Is someone? Okay, I have 2 questions. The first one is, this is a very serious problem for orthopedic surgery infection. Who should take care of this problem? In our country, the senior person and the young. Normally, we push this problem to the young trainees. That is correct or not? The second thing is that you face drug-resistant infection. I think some literature they say there is a multiple problems coming in this area where the infection is resistant to drug. You didn't mention that. What we have to do in this case? Thank you very much.
Yes, thank you very much. We're gonna take one more question from the audience, and we're gonna hear some from our moderators before we. Any more questions from the audience?
Thank you very much. So my question is for FRIs usually, if there is a bone cup, we usually use cement as a carrier. But apart from that, we just strictly the antibiotics. So I would like to know your suggestions on the use of carriers and what cheap carriers are there at our disposal. So your suggestions on the use of carriers for local antibiotic delivery instead of just strictly giving carriers for local antibiotics. Yeah.
Okay, thank you, Dr. Mario from Boston, for the nice presentation. So, As we know, Esot is very sensitive, and Esot this year, body structure related infection, it indicates that infections after surgery are sensitive and all based on our local setup and based on the principles we have discussed, we have to deal with these topics. So we have seen what are the principles, definition, there is a criteria to say there is an infection or no, means the two main confirmatory criteria and suggestive criteria. These are very important to deal with active infection. And the other thing is regarding the treatment, already we have seen the classification and the factors which should be addressed in the fracture. So thank you for the presentation and
Okay, thank you, Thank you, Dr. Mario, and our moderators. You can go to your seats. Let's give them a round of applause for the presentation. So, a few messages for you before we leave for lunch. You have received two different cards. One card says Alan Anything, and the other says the Marathon Hall. So they're both downstairs outside of this building on your right. They're side by side. For those of you with a card that says Alan Anything, you should go to that hall. And those of you with a card that says Marathon Hall, you should go to the Marathon Hall. Okay? The names are written at the top of the door, so you won't miss it. But I would like for you to slow down and first let those with the Alan Anything exit first, and then those with the Marathon card can follow. And this conference has CEU hours. So for attendance, you get 4 CEU hours certificates at the end if you have 100% attendance. So please make sure you sign in attendance for all the 2 days. You don't want this on the CEU units. And for presenters, we're going to be having 10 hours of CEU. So don't escape, don't go anywhere, stay here, make sure you sign the attendance. Thank you.